So I'm pleased to introduce Jim now. Jim has a huge bio, so but I'll say a few words. And I'm very pleased because um, coming from Partners in Health reminds me of my years working in TB with Paul Farmer and Jim Kim when we were a little bit younger. So, and it's very nice to see how much Partners in Health has grown from TB now looking at cardiovascular diseases and so on. So, Gene, it's at the, heads the global non-communicable disease and social change program at Harvard Medical School. He's an assistant professor of medicine and assistant professor of global health and social medicine. He is also the senior health and policy advisor on NCD in Partners in Health. And he's recently been chosen as a member of the financing working group of the World Health Organization Global Coordination Mechanism on NCDs, and you heard he's also lead the Lancet Commission. So plenty of accolades for Gene. So Gene is going to tell us about addressing the convergence with integration service. Please, the floor is yours, Gene.
Okay, great. So I think we've heard some really great country-based examples of some issues around integrated service delivery, and I'm going to try to in some ways be a little bit more abstract. Let's see, are we? It's not projecting. Maybe while we're so. You know, this term, integration science, I want to make a distinction between that and something that we call implementation science, I think more conventionally. And the reason why I think that we need this term and we need to recognize this field is that essentially we have an approach to kind of looking at delivery models essentially and sort of studying how well they perform, their uptake, barriers to uptake, but we don't really have a science of design of delivery, which in my mind is what integration science would be, and it may involve different kinds of techniques and approaches than actually trials. So I've been showing this slide for a while. You know, my main clinical experience in Africa has been in Rwanda. I've you know, I think as I mentioned in the prior panel, maybe I've lived and worked there for quite a long time over various periods of time. And about the time that we, as Partners in Health, started working in Rwanda around 2005, if you looked at the burden of disease and ranked the conditions by the total number of DALYs, one interesting pattern that you would see is that essentially the MDG agenda largely belongs on the left side there, right? That's in yellow. And then what we might call the non-communicable disease and injuries fall on the right side, and they kind of naturally splay out that way. Now there's a little bit of jerry-rigging here in terms of like how you group things, but even if you don't group them, you just do raw, like lowest level causes, this is sort of what it looks like. And one thing that it really points out is that, in a sense, you know, if you had like a global pneumonia or ARI initiative, as we did at WHO prior to IMCI, you know, that's a pretty legitimate thing to go after, right? Like you've got a huge burden of disease there from pneumonia, and if you look at it from an equity perspective, it's largely in children. And that's the case for a lot of these things. HIV, diarrheal disease, TB is in there. So even in that space, there was a kind of art, I would say, of delivery design, right, of attempts at integration. So some things were maybe more vertical. You had universal access to antiretroviral therapy in some cases. In some cases, there was an attempt, as in the case of diarrhea, malaria, and pneumonia management for children, development of integrated management of childhood illness, IMCI. Again, more vertical initiatives around insecticide-treated bed nets. So I think that what looking at this sort of points out is that whatever you have to say about the nature of the NCD and injury burden, you're not having the same population health impact if you have a vertical cervical cancer initiative, right? It just isn't as big a deal. And so if you labeled all of those things, I'm just labeling some of them, you would see an enormous heterogeneity of conditions, many of which from an ethical standpoint, in terms of the cost effectiveness of the intervention, the population that's affected, the poor, the children, share many properties with the diseases on the left. But they, if anything, to have a population health impact, you need to be thinking managerially, operationally about how do you integrate, right? And so there might be some hypotheses about what would fall into what, and we heard Sylvester give some examples of what that kind of clustering would be. Now, an interesting thing to look at is that so this is in 2004, and we're talking here about convergence. And one of the interesting things about Rwanda, like say if you looked at GBD now in Rwanda, what does it look like? So if you looked at 1990 and you had the ranked causes of disease burden, all age disease burden in Rwanda on top, and you have the ranked causes now, what you really see is that it's kind of all tail, right? Because the diarrhea, major childhood illnesses, basically causes of death have really declined dramatically. And as we said earlier, they were not, in truth, really dealt with through the health system, right? They're things that can be dealt with largely through community-based interventions and maybe at health centers. They don't require hospitals. They maybe even don't even require functioning health centers to any great degree. But we're in this phase where it's kind of all tail, and we're dealing, even I think in the infectious disease space, with a lot of issues that share more properties in terms of their complexity and lack of major public health impacts, such as drug-resistant TB, as Marcos is well familiar with. So in essence, this major decline in childhood deaths has flattened the disease distribution. Increasingly, the problems in the infectious disease and the RMNCH space are also what we might call long-tail problems. So we have this issue where we have a lot of prioritized interventions, but we don't have a pathway really from that to integrated delivery. And I'll just list off, taking something like disease control priorities 3, maybe adding a little bit more input from local sources, and you sort of looked at things that are as highly cost-effective and as compelling from an equity standpoint as priority infectious disease and maternal child health interventions. And I'll just list off, medical management of acute decompensated heart failure, secondary prophylaxis of rheumatic fever, treatment of acute pharyngitis, sickle cell screening, management of type 1 diabetes, relief of urinary obstruction by catheterization or suprapubic cystostomy, prophylaxis for bacterial infections in sickle cell, appendectomy, removal of the gallbladder, hernia repair, colostomy, management of bowel obstruction, repair of perforations, combination therapy, including low-dose corticosteroids and generic disease-modifying anti-rheumatic drugs, including methotrexate for individuals with moderate to severe rheumatoid arthritis, surgical treatment of early-stage breast cancer, management of epilepsy with generic anti-epileptic medications, shunts for hydrocephalus, fracture reduction, integration debridement of open fractures, tube thoracostomy, trauma laparotomy, trauma-related amputations. I'm just giving this list to give an indication that you're not going to go very far with trying to scale tube thoracostomy, right? Like if you have like an initiative, like I really want to increase coverage of tube thoracostomy, that's not something you can really operationalize. There's no operational clarity there. So what we need is something as a science that will be the study of delivery model design, including optimal clustering of tasks among providers and interfaces with and outside the health system. And it's the missing link between evidence-based interventions, health sector priority setting, and implementation. And this has some precedent in computer science. This is written by the daughter of a mathematician called Richard Bellman that sort of was the father of optimization theory in applied mathematics. And as is here, this is sort of a hopeful term It's aspirational, and we're, I think, in early stages of it. But we're in our group, which, as I think Sylvester is sort of mentioning, is what we call the Global Health Delivery Partnership, involving Partners in Health, teaching hospitals in Boston, Partners in Health, Harvard Medical School. And we work with about 16 countries now that have been undertaking national NCDI poverty commissions. We recently had an event at the Prince Mayadal Award Conference in Bangkok to sort of talk about this issue in the setting of universal health coverage and how NCDIs are really bringing up this problem. We've also been having a monthly journal club at Harvard and are hoping to build a center really for this work. You might imagine there's some principles of planning for the long tail, leveraging inefficiencies, decentralizing progressively, optimizing clustering of related services. And I'd like to take you through just an example in Rwanda of what kind of an intuitive approach to this would be, but I think that we need much more structured and approaches that involve modeling, in fact. And this gets to, I think, what Sylvester was saying about that it's not, integration is not a binary yes or no. It's really a term about these issues that we talk about in terms of optimal clustering in effect. And so you can imagine there might be a typology of chronic care services, and in a country like Rwanda, where the health system was devastated, initially you have a very high centralization of health services in the sense that they're only available in teaching hospitals. And over time, there's progressive decentralization, cascades that people recognize. And there's decisions about what things go with what based on shared competencies. In Rwanda, that was initially mental health, neuropsychiatric care. TB was decentralized then, but there's this real gap around 2005 when we started working on NCDs, and particularly severe NCDs like type 1 diabetes and advanced rheumatic heart disease. And so at Partners in Health Ministry, we developed a delivery model for that level that's in purple. And by 2015, this had not really been decentralized yet to all the, to health centers, but it had been established in all the district hospitals. Meanwhile, now in 2019, 2020, Rwanda is decentralizing simpler, more standardized chronic care for NCDs down to health centers and developing integrated chronic care, both at health centers and the community. And so one thing that this really highlights is there's a certain logic to this cascade and prioritizing perhaps early packages at district hospitals. And this is something that recently with the World Health Organization in the Afro region, we've been terming PEN+, in that it fills a gap in WHO's delivery packages and maybe an early priority in universal health coverage. We've published outcomes from this experience in Rwanda for different diseases, and also costing, which is coming out in BMJ Global Health shortly. So I'll just end with developing a science of integration and global health delivery. So some issues that really are key here is defining what is being optimized, what we're trying to optimize. Is it equity, cost effectiveness, financial risk protection? Are there other things that we're trying to optimize? How do we define the properties of the interventions and their related competencies so that we can understand their underlying structure in terms of what goes with what? And how do we study and characterize historical team structure and task distribution within health systems? And then how do we model optimal task redistribution? I think these are some of the some of the kind of work that even Rachel's the paper that she talked about in terms of the example of integration of, say, hypertension, diabetes, cervical cancer, and HIV. But it's a much broader issue in terms of the health system when we recognize the large number of attractive interventions that we're looking at now. So thanks, and looking forward to the rest of the discussion.
Thank you, Jim, for guiding us on integration science. So we're talking about integration now. We're going to talk about integration science. But one thing that struck me is that if we want to integrate further and synergize, Jean showed that we need to take into account burden of both. It's not that one is higher than others. We showed that still in Rwanda, huge burden of communicable diseases, and also an increasing raise in increasing burden of non-communicable diseases. Today, for instance, in Latin America, the highest burden is non-communicable diseases because the disease program has done well in the past, and they are eliminating some of the diseases. But it is important because we don't want it to make the same mistakes of before. So synergy and integration take into account both and bring the community, as the Partners in Health is doing in Rwanda.